Hi, I just wanted to give us some housekeeping details before we get started today. We are recording today's session. We'll make that recording available on the UMTRC website, and we will also be hosting the slides on the website. That'll take a couple of days, but you'll get an email when those are posted on our website. We also ask that you use the Q&A function today for questions and only use the chat for technical issues. We've got quite a number of registrants today, and we want to make sure that we get to everyone's questions. If we don't have time, then the Q&A function does record those questions, so we can do follow-up FAQs if we need to.
Well, good afternoon. Let's go ahead and launch into today's session. My name is Dr. Cody Mullen. I'm the Policy, Research, and Development Officer with the Indiana Rural Health Association, being joined by my colleague, Becky Sanders, who's the Program Director of the Upper Midwest Telehealth Resource Center, as well as the Senior Director within our association. We're honored to present this session. That was a sponsorship from the Region 5 Public Health Training Center being hosted at the up at the University of Michigan, focusing on public health and the use of telehealth technology. And with that, I'll go ahead and turn it back over to Becky to continue on through our session.
Thanks, Cody. All right. So we're just going to talk about some basics of telehealth and telemedicine. I'm going to give you some technology tips. We're going to do a very, very high level talk about reimbursement, and then get into some public uses, public health uses for telehealth and telemedicine. And hopefully at the end, we'll have a few minutes for Q&A. So the Upper Midwest Telehealth Resource Center is one of 12 regional telehealth resource centers around the country. And we also have two national centers, a national center for policy and a national center for technology. The 14 of us are all funded through cooperative agreements with HRSA, the Health Resources Services Administration, under the Federal Office of Rural Health Policy and the Office for Advancement of Telehealth. We do have a national website, and they do host monthly webinars through that website. There's also different resources, and you can, through an interactive map, contact any of the 14 of us via the national website. Here at the UMTRC, I've coined the term virtual librarians. That really takes into account all that we do on a day-to-day basis. If you send an email through the national website or through our regional website, or call our 800 number, we call that technical assistance. And a lot of that is answering specific questions about reimbursement, policy, best practices, those types of things. And if there's someone comes to us with an idea, or they want to do a NICU virtual telemedicine program, then we would reach out to other programs like that and see if they would be willing to talk to the new program so that they could share best practices and not have to reinvent the wheel. We do a lot of presentations like what we're doing today. Of course, over the last few months, they've all been virtual via webinar and not really in person. There are multiple ways that you can get a hold of the Upper Midwest Telehealth Resource Center. We have our website. We also have a Facebook page and a LinkedIn page. So telehealth and telemedicine, I always like to start by defining these terms. They're often used interchangeably, and I myself often fall back on the word telehealth, as many folks refer to it. But the realm of telehealth is the bigger overarching term for anything using data and healthcare in a virtual situation. And then telemedicine is that actual billing for that clinical encounter. And we'll walk through some examples of both of those. So when you talk about telemedicine, it can actually be asynchronous or synchronous. And those of you with a data background before voice and data systems were combined may recognize those terms. So asynchronous is often used with dermatology, where you take a picture of a wound or a rash. Your primary care doctor might take that picture and then send it to a dermatologist for evaluation. And radiology is a perfect way to think about asynchronous telemedicine. And then synchronous is that live and interactive audio-visual connection between a patient and provider when the two involved in it are not in the same location. And then when you start talking about the different types of telehealth or telemedicine programs, I always want to make sure to emphasize that telehealth is not a service in itself. You're delivering telehealth. No, that's not correct. You're delivering primary care via telehealth. Telehealth or telemedicine is just the modality of delivering that care when the patient and the provider are not in the same location. So I mentioned our National Technology Center. This is the link to their website. They have a lot of toolkits. They are getting ready to release a very comprehensive toolkit on video conferencing platforms that have just exploded over the last several months with COVID-19. When you click on this toolkit icon, this is what you see. So you could look at video platforms, you could look at the reviews they've done of digital stethoscopes or patient exam cams. They have a special section for home telehealth, and we'll talk just a minute about that as well. So if you are a larger organization, you might have your electronic medical record on Epic or Cerner or Meditech. Those are some of the big names in EHRs and EMRs here in the Midwest. Your organization might be a Cisco shop. Maybe you use WebEx or GoToMeeting or Microsoft Shop. Every organization, and especially the larger organizations, are going to have internal IT resources. And when you think about converting a program from a face-to-face program to a virtual program, you really need to rely on your IT folks. It doesn't cost an arm and a leg like it used to. Technology has gotten so much better and cheaper, and there's many ways to make that virtual visit happen. So I encourage you to check in with your folks and see what you've already have in-house as far as video conferencing platforms that can be HIPAA compliant. So before 2020, before coronavirus and COVID-19, when we talked about telemedicine, we would really talk about using an existing patient room and rooming that patient in an existing patient room. And so we would talk about these things about, what do you need in the room, exam table, chairs, maybe there was whoever the medical assistant or the nurse rooming the patient would go ahead and take those patient vitals and then enter them into whatever system that particular office is using. Today, our discussion has really changed. We're talking about patients staying at home and seeing a provider virtually from their home. In fact, in some instances today, still with COVID-19, providers are also at home and they're not in the office. So then the question becomes, well, if you're doing a primary care visit, how do you get those vitals from the patient? There are consumer devices that you can purchase. I think we're going to see many more vendors get into that market in the next 6 months. But think about it right now. If you think about what type of medical devices you have in your home, I'll bet you have a thermometer, and certainly a patient could take their own temperature and just tell the provider on the other end, and then they could mark it down in the chart. Most houses also have blood pressure cuffs. You might have a patient that has some type of activity monitor, either on their smartphone, or they might wear a band on their wrist, those types of things. Any data that the patient has and can give you is okay to use in that medical record. We do recommend that you make a note that it was patient-provided data. Consent and video etiquette, we have done several virtual office hours, and just as we're going to post this recording on our website, along with the slides, we have done specific sessions on video etiquette or webside manner and also on consent and documentation. We're not really going to touch on that today. We're going to direct you to those other existing resources. But I will say just two things, that for video etiquette, you want to make sure that you have a clean and uncluttered view between the provider and the patient. So even though my slides are over here on this screen, I've got two screens going, I'm trying to make eye contact with the little light in my webcam to show that I'm talking directly to you. I'm not over here talking to my slides. So that's very important when you're having a video conversation with someone. And then on consent, here, in every state is a little bit different on consent. Here in the state of Indiana, you do need to obtain consent. And right now you can obtain that virtually. The provider could read a consent form and get verbal okay from the patient to be seen via telemedicine, and then that needs to get logged in the electronic medical record. You could also, if you've got a patient portal, you could send that consent via the patient portal for them to print, sign, and fax back, or scan and email back, or you could do snail mail. But you do want to make sure that you get that consent on record. All right, so now we're going to jump into federal policy, Medicare, Medicaid. So at the federal level with Medicare, everything is paid based on CPT codes. And for years, since the late 1990s, when Medicare first started paying or reimbursing for telemedicine visits, they have done so based on the rurality of the patient's location, with the idea that in a telemedicine visit, the provider is more likely to be in an urban area and the patient is more likely to be in a rural area. So there's different conditions that we'll go through. And we'll talk about all of the waivers that have happened with COVID-19. For Medicaid, each state and the District of Columbia have flexibility to do what they would like to do and cover what they would like to cover as far as reimbursement specific to telemedicine. Each state's different, and their approach to their Medicaid programs are different. As of the spring of last year, all 50 states and Washington, D.C. do cover live and interactive telemedicine. We'll see an update to the Center for Connected Health Policy's annual scan that they do every 6 months, and we'll look at some other details and similarities between different states when it comes to their Medicaid programs. All right, so here's the 4 requirements for Medicare reimbursement at the federal level. So the patient needs to be outside of a metropolitan statistical area. They have to be in a designated originating site. The services delivered have to be within a certain CPT code range, and they have to be delivered by eligible practitioners. So right now, with COVID-19, one of the first sweeping changes that made such a huge difference in delivery of Medicare to patients during COVID was these first 2. The patient no longer has to be outside of a metropolitan statistical area, and the patient doesn't have to be at a designated originating site. Those 2 things were waived during the public health emergency. So that means the patient can be at home and they can be in the middle of Chicago or Detroit or Indianapolis or Springfield, Illinois. These last 2, the services do have to be within a certain CPT code range, and CMS has issued multiple FAQs with expanded lists of codes that are eligible for telemedicine reimbursement. They have also expanded the list of eligible practitioners. They've included, for the duration of the public health emergency, physical therapists, occupational therapists, speech language pathologists. A couple of other areas that we've had a lot of questions on but have not seen any movement to date has been on diabetic nurse educators and on genetic counselors. Those two have not been expanded. All right, so if this was normal and if we hadn't had a pandemic, how do you know whether or not you're in a rural area for your patient to be reimbursed for Medicare via telemedicine? And this is the website that you go to for that. But again, this is waived right now during the public health emergency. Every year, Medicare puts out their Medicare Learning Network Telehealth fact sheet. And this is their guide to what can and cannot be reimbursed via telemedicine. So this is the gold standard, telling you exactly what you need to do to be able to get reimbursed. So the sheet looks something like this. It lists all of the different services and then the different HIPAA or CPT codes associated with those services that can be reimbursed via telemedicine. This fact sheet also contains information about the type of originating site, which is where the patient is located, what type of practitioner, and all the billing and the modifiers and all of those procedures are within this. They released it this year at the middle of March after some of the 1135 waivers were starting to come out of CMS. And so this does link back to the CMS COVID-19 fact sheets and some of the early frequently asked questions. All right, so this is what a normal billing situation looks like with telemedicine. So I've used some of these terms already. I've talked about a rural site or a patient site or an originating site. It's also called a spoke site. So those terms, between different Medicare, Medicaid, and commercial insurance can be used a little bit differently, but they're all referring to the patient location during the telemedicine visit. And the way that normally gets billed is via Medicare Part B facility fee. That Q3014 is the CPT code. It's only around $25. It's not a lot of money. And we do see this also in Medicaid and private payer. But since CMS, Medicare was the first to reimburse for telemedicine, they're often setting that goal, and then Medicaid and private payers will come along behind them. So right now, with the COVID-19 public health emergency, if the patient's at home, they're not at an eligible, well, it's waived, so it's eligible, but there's no billing for the facility fee when the patient's at home. That fee is created and to be used to recover the costs for rooming a patient in a clinical facility. So if the patient's at home, there's no need to recover that cost. So it is not billed. Then on the provider side, it's the same. They bill on their Part B professional fee. They bill their normal CPT code as if the patient were being seen in person with certain modifiers. And that can be referred to as the urban site, the distant site, the hub site, the provider site, all of those things. That's basically where the provider is during the telemedicine visit. And there's been waivers. We'll look very, very, very high level at several of the waivers that have come out since March, and providers now, during this public health emergency, can be in any location. They do not have to update their information with CMS to say that they're working from home instead of the office, or working at a remote office or whatever. That they don't need to update any of that. All right, so just a little bit about different types of billing for telemedicine, really thinking about when the patient's at home. So there's two codes here that you can use synchronously or asynchronously, and you can use the telephone for these. And these are G2010 and G2012. These are considered virtual check-in codes. So that's a very short visit. It's supposed to be something that is with an existing patient, an established patient, not tied to something in the last 7 days or in the next previous 7 days, or after that in the next 7 days. So these are short conversations between a patient and provider that are basically keeping the patient from coming in to a clinical facility. Speech language pathologists, PTs, and OTs can also do this, and they use codes G2061, 2062, or 2063. The different codes are for different lengths of time. But note, the reimbursement for these is very low. It doesn't matter where the patient is, doesn't matter where the provider is, phone or video, but low reimbursement. We also have interprofessional or internet EHR consultations. These are often called e-consults. So these are provider to provider consultations about a specific patient. For example, maybe Cody is my primary care doctor, and then he needs to consult with, I don't know, a cardiologist about my care. So they can each bill to my insurance for having a consult between them about my care. And this is all designed to facilitate the patient-centered medical home. A lot of this is used when providers are part of accountable care organizations, those types of things, to be more patient-centered in the medical care. And then e-visits, again, this is a review of the codes we've seen before. So very similar to those virtual check-in, the 2010 and 2012. And you see here how they're tied to a cumulative time during the previous 7 days for 5 to 10 minutes, 11 to 20, and 21 or more. And then you can also do online medical evaluations, and those are the codes for that. So these are services provided to patients that are not necessarily telehealth, because they fall outside of the normal CMS telehealth guidelines. They are not subject to the criteria of the location of the provider or the location of the patient during the visit. And there's more room as far as eligible providers. It could be a mid-level doing these services under supervision of a physician or a nurse practitioner. And then finally, one of the biggest barriers that we had in the midst of COVID in the April timeframe was really, how can Medicare providers stay in contact with their patients if their patients don't have computers, don't have adequate broadband, don't have tablets, don't have smartphones. There's no way for them to have a virtual visit. So at the end of March here, you see 3/31 of 2020, CMS did add several services that were telephone only, several codes telephone only. So these are the codes for that. Other waivers that happened, some at the end of March, some at the end of April, and some at the end of May. There were over 80 new CPT codes added that could be used for telemedicine. There were waivers for workforce and supervision, allowing that to happen virtually, allowing providers, as I mentioned before, to not be in their normal location, basically to be at home and delivering services. Waivers for provider enrollment, several waivers related to patients' care over the paperwork, Stark Law waivers, signature requirement waivers, waivers on consent and documentation. I talked about an audible reading, the provider reading that consent language to the patient and an audible back instead of a wet signature. There were also changes to MIPS recording, and there were accelerated and advanced payments in many cases as well. All right, one area that we do get questions on, especially when it comes to behavioral health, is prescribing via telemedicine. So the DEA did put out some information amidst all of this, and we've got the link to that site there where you can dig into that if that's something that pertains to you. They have specific policies about electronic prescribing of controlled substances, and different policies around medication-assisted treatment as well. And this is the language they put out at the beginning of this year. Basically, this is the policy. You can, during this public health emergency, with the 1135 waivers, you can prescribe to a patient who you're just meeting for the very first time via telemedicine. You don't have to have been, the patient doesn't have to have been seen by the provider in person before they can prescribe that substance. The communication, the telemedicine communication does have to be conducted using an audio, visual, real-time, two-way interactive communication system. So it can't be a telephone call. And then the practitioner has to be acting in accordance with applicable federal and state rules. And the way that I interpret this is that basically they have to be signed up, and they have to be a DEA prescriber or at a DEA facility and have all that in place in order to be able to do this. And it does have to be within their current scope of work. So amidst all of this stuff for COVID-19, our website is one of our biggest resources that we have for folks. And we did stand up a specific resource on our website that had, and it is still there, breakouts for the different states that we cover. So we cover Illinois, Indiana, Michigan, and Ohio, as well as Medicare information can be found at this link as well. And looking at, so the other big thing that happened that has made it a lot easier for patients to be seen via telemedicine is the relaxation of the HIPAA rules. So for the length of the public health emergency, and again, each state does things a little bit differently with their Medicaid rules. You can see the language here, but they're all similar. And what they did is they said, right now, it's more important to take care of your patient than to make sure that you have a HIPAA-compliant video conferencing platform to deliver services. So it's okay to use things that aren't HIPAA-compliant, like Facebook Messenger video chat or Google Hangouts, or other things. But you don't want, even the telephone, all 4 states that we cover did make exceptions for telephone care. But you cannot use things like Facebook Live or TikTok or Twitch that are public facing. It still has to be a private communication between the patient and the provider. And we do our website etiquette and talk about patients being seen from home. Really, you have to take into consideration what is the surroundings of the patient and the surroundings of the provider. It needs to be as private as possible with as few distractions as possible. You certainly don't want to be in a drive-through at a restaurant or outside at a park with lots of activity going on around you. You want to make sure that still a communication, that visit between the patient and the provider are still private as much as possible. And throughout all of this, the Upper Midwest Telehealth Resource Center continues to recommend that you use HIPAA compliant technology. You want to make sure that you're doing the best that you can to provide security for your patient and their health information. All right. Similar to the COVID resources that we put up on our website, we do have state-specific reimbursement summaries, information on Medicare and state Medicaid programs, private payer laws. Those can be found at that link there. We have been able to step back and integrate all of the COVID information, all the waivers in each state reimbursement summary. So those are available and updated on our website as of last week. I mentioned the Center for Connected Health Policy earlier, and I wanted to provide you with the link to their website. And I talked about, so every 6 months they do this scan of all 50 state Medicaid laws and private payer laws. So this was just released maybe 3 weeks ago now. So there's spring 2020. Again, we had 50 states that have definitions for telehealth or telemedicine or both. All 50 states do reimburse for live video. 19 states actually reimburse now for services to the home. Ohio started reimbursing for services to the home in July of 2019. Michigan had already planned on doing this in March of 2020, and they got their legislation on the books right as COVID was hitting. So we anticipate that that will stay the same once the public health emergency is over. There are 23 state Medicaid programs that reimburse for remote patient monitoring, and 16 that reimburse for store and forward. A couple other interesting statistics about online prescribing, some different state actions around that. In our region for Illinois, Indiana, Michigan, and Ohio, we had new prescribing laws allowing providers to prescribe for existing patients via telemedicine in the 2017 timeframe, with caveats around controlled substances and that kind of thing. 42 states do have private payer reimbursement, so the commercial providers, Aetna, United, Blue Cross Blue Shield, Anthem, all of those do reimburse. There is some sort of private payer law in all of the 4 states that we cover. And then 39 states have specific language around consent. So with everything that we do here at the Upper Midwest Telehealth Resource Center, our goal is to increase access to care. Now today we've been asked to talk about public health and the use of telemedicine and technology. And at this point, I'm going to hand things over to Dr. Cody Mullen.
Thank you, Becky, and thank you for those who are still listening in. We already have one question, and we're making sure we have about 15 minutes at the end of today's presentation for a question and answer. So if you have other questions, please, while I'm going through the next few slides, feel free to type those in, and Becky and I will field those at the end. And please make sure you click on the Q&A and not the chat for those messages so we can better track those. So recently we were made aware at the UMTRC about a new site called Fair Health, which does various different research using publicly available data sets in more of an infographic way. So we're going to be looking at what are the telehealth tracking for the country, and then for the region, we're going to be looking at the Midwest, which is highlighted here, which is greater than both the UMTRC region and also the RVPHTC region, but it's most refined data that we can have. Next slide, please. So if we look at, and if you go to the website, you can really drill down in this data. So if we look at nationally, what were some of the changes in time from the first quarter, so January through March of 2019 versus the first quarter of March 2020. So we're able to start to capture a little bit, maybe about 3 to 4 weeks of the COVID pandemic in the new data. One thing that was of interest was there was a 4,300% increase in the volume of telehealth from 2019 through 2020, as shown there in the upper right-hand corner of this slide. So of claims, about 0.17% in March of 2019 were a telehealth claim, but then in 2020 that spiked all the way up to 7.5%. We saw that increase also in urban and rural, and as Becky mentioned, the softening of those rules for that rural designation site. So now we're seeing that we are seeing urban actually has more volume than rural when it comes to telehealth. But of interest, if we look at the top 5 diagnoses that were treated via telehealth, mental health is obviously the #1 condition treated via telehealth. So 44% of all telehealth in 2019, March 2019, was related to mental health. That decreased by 10% down to 33%, 34% in March of 2020. And then that next most popular was acute respiratory disease and infections. Again, we saw a decrease in that over time. And then we saw a new adoption of hypertension and general treatment of conditions. Next slide, please. But when we look really at our region, which includes both of the people on this slide, or on this presentation, we noticed that we did see an increase in telehealth, not as pronounced as the country, only a 2,800% increase to telehealth. We did see a very similar increase in urban versus rural and increasing the usage of telehealth. But we actually saw an increase in the utilization of mental health services in our region via telehealth. So remember on the national slide, that previous slide, we saw a decrease as a percentage of overall telehealth claims. Here we're actually starting to see an increase. And we also saw a greater decrease, though, as a percentage of acute respiratory diseases. So just as you're in your public health department, and we're going to start doing, I'm going to lead you through some questions that you have within your public health department, but just kind of what's happening nationally and what's happening within our region. We are seeing that huge demand for mental health services. Next slide, please. So as we're really trying to angle this presentation around local public health departments and utilization of telehealth, and some local health departments, all the CPT code discussions that we have is right in line with the needs that you have. But for others, you're not currently billing for clinical care services. You're offering other services either as a good to your community, so you're not getting direct reimbursement for that, or you're doing it, other programs that maybe are outside the traditional healthcare scheme of delivery. So as you're thinking about these, what are some of the locations or service sites that you could offer telehealth in a public health format? What are some of the spots that your community goes to on a regular basis that has privacy for individuals that can utilize telehealth? Maybe that's a library. They have an ability to put a webcam-enabled device, either a tablet or a laptop or a desktop, in a private room that someone can go into and have a telehealth visit with your public health nurse or with other members of your public health department. There's no stigma there. They're going in the library, they're going into a private computer room, but they're able to have that discussion. As we're in this COVID-19 environment and as we're starting to prepare for a potential spike of cases this fall, we still don't know what's going to happen, but now we can start to build our capacity towards what happens if another pandemic were to occur. Could you do contact tracing or testing result follow-ups via telehealth? Is there a better value add to your community when you give the news that you did test positive for COVID-19 to do that via a FaceTime encounter or a Zoom encounter where you can see each other's faces, can immediately answer questions on a simple phone call or a letter going through the mail? As we're looking at infant mortality, which is a huge issue of public health, and maternal mortality, how can you better support your expecting and recently delivered mothers and their babies through the utilization of telehealth and telebehavioral health services? Instead of doing home-based monitoring, right, we probably don't have public health nurses going into the community as frequently as pre-COVID, just based on the amount of PPE that needs to be downed for each home visit and things like that. How can you transition some of those things that you're already doing into telehealth delivery? What clinical care, so if you're a more advanced public health department that does bill for clinical care, what clinical care do you already offer that you can transition over to public health, over to telehealth? Are there things that you're already doing that your consumers, you'll have better adoption? Personally, I've been able to use telehealth several times during the COVID-19 pandemic, and now why would I ever want to go to a doctor's office and lose 3 hours of my workday when I can do it in between my usual calls and have about as good as care as I would have otherwise, depending on the symptomology and the treatment that you're requesting. And then lastly, public health departments, publicly funded, you don't have excess resources, excess capacity, excess space, but what new services do you want to be able to offer? But space is your limiting factor that could be delivered via technology. Is there a support system that you're just out of rooms on Tuesday nights to offer that a Zoom connection would be just as good offering those services? Is there a one-on-one counseling around nutrition that you simply don't have the space for your nutritionist and that patient or consumer to meet together and discuss those things? So I challenge you as you think about public health department, and our first question is really going to get into this as well, of how do you change, how do you flip up what has been the status quo? And as Becky mentioned, right now is a great time to experiment because the regulations federally and in states are very low due to the pandemic. As things are changing and as some of those regulations are reintroduced, make sure you're building things towards HIPAA compliancy, right? A Zoom license that's HIPAA compliant is an extra about $50 a month. And I use Zoom as an example. We're technology agnostic, but you can also get HIPAA compliant FaceTime and other things like that that do have a minor cost to it. But now is a great time while you're waiting for those things to be set up to get started. So with that, I'll go to our next slide and leave about 20 minutes for questions and answers. So please be using that Q&A feature for that. Also, Becky and I's contact information are both posted here. Please feel free to reach out to either one of us for other conversations. So our first question comes in about what about certified health education classes and groups? And if you could, Crystal, if you could please add a little bit more about your question there. I guess my question to you is, are those things that you're currently billing for? If not, and they're just things, classes that you're offering to better support your community, then some of the regulations are not there, right? You want to make sure you're HIPAA compliant because you're sharing protected health information potentially during those classes, but you have a lot of things about that. She was talking about billing. Can we bill? So looking at those individual billings, if it's a CPT code that you would bill via Medicare, Medicaid, or private insurance, please let us know. We can share with you the document that lists all the codes that are eligible for that. If it's a different kind of billing, that would be between you and the payer if they pay for that. Becky, do you have anything else to add on that?
Yeah, and I would need more information, Crystal. I would encourage you to go ahead and email me. So we need to know what type of certified health education classes you're doing. Who is the audience? Is the audience Medicare or is that Medicaid? If it's Medicaid, what state are you in? So to be able to drill down into the appropriate policy and answer those questions.
Great. Next question comes from Lauren. Is there any information about the effectiveness of infant maternal programs that were typically covered in home compared to telehealth? Becky, I'll turn that one to you if you have any.
Yeah, I'm going to stop sharing my slide. Autumn will put our email addresses in the chat, and I'm going to go out to the website. So one of my sister telehealth resource centers, the Northeast Telehealth Resource Center, has a wonderful website where they collate all kinds of research. So I'm going to take a look at that, and I'll put the link to that in the chat so that you can have that. I'm sure that there's something out there.
And a lot of the newer studies that are being done, we're seeing in the literature a lot of post-COVID discussions in literature of initial studies that are being done that have been IRB vetted. So as those come out, please be checking the UMTRC website. We'll be able to add those resources out there as copyright and things like that allow. Otherwise, partner with your university connections to get access to those articles.
Absolutely. So I'm putting in the chat the link to the Northeast Telehealth Resource Center, to their resource library. Basically, it's a keyword search. You can filter by specialty, by year, by region. And I'm sure that they would have something about infant maternal programs. I know also I've seen in the chat, Autumn put in a link to a survey. Because we are federally funded, we are asked to get feedback on the programs that we do. It's just a short 3 or 4 questions, and we would appreciate your time in answering that.
Other questions? So we got one. With immunization rates decreasing, what would be a guidance or resource for providers to implement with telemedicine?
Something that we're really looking at here is health literacy. As part of the CARES Act with COVID-19, we've gotten some extra funding, and we're going to do more webinars and resources on our website that are more consumer driven, because everything that we've done up to this point has been very provider focused. So I think it's really engaging consumers and health literacy. And we see in some of the school programs where different cultures they don't have it's just not part of their family's culture, their family's history to, okay, every year you go to the doctor and you get your shots and you go to the dentist every 6 months. So I think it's a learned behavior that we really have to focus on with those that aren't getting their immunizations.
I also encourage you, another project we have here at the Rural Health Association is looking at how do you utilize Facebook or TikTok or other social medias to have that as educations get in front of people on where they're already at, then making them seek access to, I want to learn more about this, I'm going to go to the public health website.
Mm-hmm.
So another area to look at. Other questions? Another question just come in. Are there any information or best practices to help Medicare members utilize telehealth, specifically around engaging seniors to log on to video calls?
Yeah, I would check the CMS website. I can do a quick search while we're on here. But CMS produces a lot of fact sheets, a lot of with their Medicare Learning Network bulletins, and you can actually sign up to receive those in your inbox.
Next question. Any suggestions on how STD services can be provided via telehealth?
And I'm assuming we're talking about sexually transmitted diseases. Again, I would look just educational programs. If you want to offer webinars like what we're doing today around STDs, you know, getting, and I know we're here in Indiana. It's a very conservative state as far as talking about that with teenagers at school, and sometimes can be very difficult. But if you work with teens in any way, doing public health fairs, I know a lot of county fairs have been canceled this year. State fairs, our state fair here in Indiana has been canceled this year. But any way that you can reach out to kids, if it's a community day, maybe at a farmer's market, any place where there's a group of people coming together, I think is a chance for some education, and maybe it's in the form of handouts. Maybe you can work with your local school systems. Yeah, all kinds of options there.
Also encourage, you know, the utilization of support groups. So this is a very one-way telehealth or telecommunication, right? Only Becky and I are able to talk. And then it's text back, but a Zoom connection or a FaceTime connection where a lot of people can get together. The adoption of that is a lot more accepted now post-COVID after 2 or 3 months of Zoom everything for everyone. Great. Any other questions? Well, I'll give it another minute, but if none come in, thank you for joining this session that was sponsored by the Region 5 Public Health Training Center out of the University of Michigan, as well as being hosted by the Upper Midwest Telehealth Resource Center, hosted at the Indiana Rural Health Association. All presentation materials and questions will be posted on the UMTRC website in archive format. If there's anything that Becky or I can do to help, please feel free to reach out to any of us. You can email us at info@umtrc.org. And I see no other questions. So thank you for joining us, and have a wonderful week as we launch this middle week of June.
Thanks.